Over the years I've learned part of the problem is MS often mimics other illnesses, and it's a diagnosis of exclusion. So when you start, a physician starts, especially the patient probably is going to start with their primary care. And the primary care through interview will ask for what's going on, and the very first thing that the primary care physician will do is a Lyme's disease test, because often some of those neurological disorders are from Lyme's. And once the Lyme has been eliminated, then we'll start a various other testing. Now the patient at that point really has no idea what's going on. It's frightening. And sometimes with spinal tap they're even looking for a tumor on the spinal cord or a possible cancer. This is what was shared with me. So there's a very frightening no man's land going on for the patient during this process. I think a primary care physician should be more open of telling them what the steps are, what they're thinking, and how they're going to get to that conclusion, either by elimination or by really zeroing in on it. The MRI today has become much more sophisticated, and so it's an easier, quicker diagnosis for the patient. But as I said, they will start with Lyme's and then go from there to either the spinal tap or the MRI. And then if it's still vague, they might do an electric response system whereby they check your nerve endings on your fingers to see how you respond. But nothing is clear. It's going back many times, a lot of blood work. Again, that spinal tap is a frightening, I find, for the patient, quite scary. Just the fact that they're going into the spine is already something that is frightening to a patient, because why are they doing it? So again, I want to give credit, though, that the MRI has made it much more sophisticated and easier to get to that diagnosis. I, as the patient, don't know it's MS. I don't really even know what MS is. I am feeling numbness and tingling that's not going away. I've had it for months. It's not particularly painful. I lost my vision and it came back in 5 days. So I attributed that to being a new mother. I just had a child in 1989. So none of that I connected the dots to until that numbness and tingling didn't go away. And I was, at the time, just had taken up the sport of running. I had plantar fasciitis. My primary care doctor sent me to a physical therapist who stretched, and I did all the things you do for plantar fasciitis. Went back to running, then the numbness and tingling started. My first phone call was back to the physical therapist, and I said, I don't know what you did to my foot, because he was using ultrasound and stuff, but that I'm now numb and tingling, and it's going from the foot you were working on for plantar fasciitis all the way up to my rib cage. The physical therapist said, I didn't do that. You need to call your primary care physician. I am still thinking I pinched a nerve while out running or did something just in my everyday life. I didn't feel sick. I wasn't feeling tired. I didn't feel any kind of symptoms, flu or anything like that, that would make me feel like I was ill. I truly thought the physical therapist had damaged my foot and a nerve was reacting to it. So when he said you need to go to your primary care physician, I didn't do that. I listened because he too sounded quite concerned. He never said MS, but he definitely gave me the idea that this isn't something to mess around with, you better see. I go to my primary care physician. I say I've got this weird numbness and tingling. I never brought up that I had lost my vision 8 years earlier. I never brought up that I had paralysis 10 years earlier. I never connected those dots until much later. I was only thinking of this numbness and tingling in my left leg that wasn't going away, that was getting more pronounced and was now creeping up the side of my rib cage. From that, the primary care physician started saying, I'm going to do a series of tests. And the very first thing they tested was for Lyme's disease. I had already, unbeknownst to them, self-diagnosed myself with Lyme's. When I had that loss of vision in the 80s, when I had that paralysis, it's just when Lyme's was identified, which was around 1983. So when I had all those things, I thought possibly I had Lyme's. So I wasn't surprised when the primary care doctor said, let's test you for Lyme's. That came back negative, no Lyme's. Then they said, okay, the next step. So you're waiting as a patient. Now you're starting to get a little, you're not really scared, but it's like, wow, they're really taking this numbness rather seriously. So the next thing he orders is a spinal tap. That's when I then started to sit up and take notice. Why a spinal tap? That seems very invasive. Well, we want to take that spinal fluid and check for things. I had to push and say, what are you checking for? MS was never brought up. Possibility of a tumor on the spinal cord was. Something that was pinching the nerve in my left side to make that left leg feel numbness and tingling is what they were looking for. I had the spinal tap, which I found very scary. I ended up getting a very difficult course with it. I got the spinal headache. I ended up having to go back into the hospital to have a blood patch because the spinal fluid was leaking out. And the only time I felt any kind of comfort, which is not the right word, but relief of some of the symptoms of that headache, is if I laid perfectly flat with my eyes closed. I later learned that when a spinal tap is offered, as a patient, one should request that an anesthesiologist administer it because they're very familiar with the technique. Anyway, did the spinal tap. Shortly after, before I even got the results of the spinal tap, primary care physician then said we're going to do an MRI. I had never had one before. I know that sometimes people suffer from claustrophobic tendencies when they're in the MRI. It's a very small tube and chamber. I'm not particularly bothered by that, so I was okay, but I do know that with a lot of people with MS, an MRI can be a difficult test to take. The MRI was administered as well as an electronic response exam. All of this done within the local area of where I was living, north of Boston. Finally, after all these tests, it took a good probably 6 weeks from the time I came in with the numb left leg to meeting with the doctor with all these test results, and the doctor said, you have multiple sclerosis. I had the same reaction as all the MS patients I've ever met. We don't know what MS is. Most of us ask if it's Jerry Lewis. Seriously, that's the one disease because of being on the television that we know about cystic fibrosis. I think that's the Jerry Lewis, or muscular dystrophy. We don't know a thing. And then my next question, is it fatal? He said no. But that's where your point of reference starts. In that millisecond of hearing you have MS, your whole world flashes by. Funny how the brain goes. I'm thinking I live in a 150-year-old house. There is no way I can fit a wheelchair through those doors. Oh my God, I have to sell my house. That's what you think. It's a frightening, you're looking at this doctor, you probably can see it in your face as you're mapping out that this was not the way I planned my life. It's only a numb left leg. I'm still able to walk. I'm not falling down. I, at that moment, didn't know anything about MS nor any of the symptoms. I'm just thinking this is a lot being made out of a numb left leg. So from that diagnosis, the primary care physician now turns you over to a neurologist. I started with a general neurologist, wonderful doctor. He had a fellow with him, working for him, and the two of them said, okay, your test results all indicate, they asked for more. I had a repeat of the MRI. And from there, they said, okay, we see 4 lesions in your brain. And now we're going to give you all the information on various therapies. At that time, there were only 3. They gave me 3 grocery shopping bags filled with DVDs, or maybe they were even VCRs back at that time. Pamphlets that were very fancy, very slick, showed happy people, everything about the 3 different therapy options. I didn't know anything about MS therapy. I didn't know about MS drugs. This is one of my biggest gripes. This patient, and I'll read and things. This is all pre-Google at the time for me. They don't know anything. They've just been given this life-altering diagnosis. They know it's not fatal, and I guess there's some of that, oh, thank God it's only MS and not a tumor on my spinal cord. So I think if you were weighing it out, you're feeling your odds were pretty good that it was MS. But that's the point where everything starts and stops. The general neurologist, he sees everything. He sees headaches, migraines, epilepsy, and now MS. So you're kind of thrown into the general pool of weird neurological disorders. My other issue is, and it's still to this day is the case, you are given all those therapies in those paper bags. The doctor says, go home, read up on the therapies, and when you come back in 2 weeks, you tell me which of these therapies you want to take. How do you make that decision? How does a patient decide which therapy? They need to educate themselves just on that alone. They need to learn that they're called disease-modifying therapies. They need to learn that these therapies are not a cure. They need to look at the relapse rate. Which therapy has the best reduction of relapses? These are all new terms, new words. The doctor's not explaining them. When they read this literature or put the DVD into the video player, they're looking and saying, oh my God, it's a shot. They're thinking only diabetics need to take a shot. So all of this is coming down on them like a ton of bricks. This is where we have to start. We have to do better medicine at this point. We have to make the path much clearer for the patient. We have to define what MS is. We have to define what MS looks like. We have to statistically tell them that 85% of the MS population has something called relapsing remitting, so that they're not envisioning that wheelchair and that life is over and they have to sell their 150-year-old house. This is where we do a great disservice to the patient from that starting gate on. What is this disease? What does it look like? They can't tell you what your course is going to be. They do have some algorithms, though, where they can say, well, you were diagnosed later, 40 and on. So the information we have shows that your disease progression may not be as severe as somebody who was diagnosed at 18. But they also need to bring up what these disease-modifying therapies are and what they do for the patient and the disease. My journey with MS is not unique. In talking to others with multiple sclerosis, getting to that diagnosis is very difficult, and it's very vague. It's vague because the symptoms are different in everybody. It's vague because the disease progresses differently in everybody, the speed by which it progresses, and there's a lot of no man's land out of there. The only way that you can really start to zero in on your own is almost taking a blueprint of what life has been like up until the point that you're at that doctor getting that diagnosis. That is also how they make the diagnosis. Odd neurological disorders defined by time and space. Because an MS flare-up isn't fast. It doesn't just happen and then go away in a few days. A true flare-up or a true MS symptom stays with you. You may have it for weeks, you may have it for a week, then it goes away. It may reoccur and come back. All of this is not known by either your primary care doctor nor the patient. Connecting the dots of what your past looked like. So when you talk to patients, you will often find out that they had vision problems, they had fatigue, they had the numbness and tingling on one side, but they went away. Or they subsided enough that the person could live with it and thought, well, that's just for me. I was a runner, I was athletic, and I figured the numbness and tingling was because I pinched a nerve somewhere and had created a problem for myself. I never associated it with multiple sclerosis. It wasn't until I had a very astute physical therapist who sent me on to the primary care doctor. But other patients with MS won't connect those dots right away until something quite aggressive happens. Maybe foot drop, maybe they start to tremble, and we immediately think it's something else. We might think it's a stroke symptom coming on. We might worry that it's Parkinson's, but there is something usually for an MS patient pretty earth-shaking that prompts them to go to the physician. Those with MS fatigue realize that they're tired all the time and they can barely get out of bed. They figure it might be nutrition. They might be low on blood sugar. They might have diabetes or a thyroid disorder. That's all the information that a patient will present with of why am I tired, not just regular tired. I'm tired the minute I get out of bed until I wake up the next morning, and it repeats again all day, and it doesn't go away. They will read on the internet, they will go to WebMD, they will get all this information, and that's enough to prompt them then to head to their doctor. Primary care is where we start because that's how our medical system is set up. They probably don't even know what a neurologist is. I didn't pay attention to the subspecialties of medicine. I just was listening to my primary care physician. The patient then has to try to give that roadmap to the doctor. Often, I think the primary care specialty do a very, very good job, by the way, of taking that information, if they listen well, of taking the information, putting it together, and starting to formulate a picture of what this patient is showing. I don't know if they're necessarily thinking MS, but I think that the primary care physician is definitely saying we need to test beyond what I'm hearing. What is causing the fatigue? They'll probably do a blood profile. Is it low iron? I mean, how easy would that be? So as I said, it's by process of elimination that the diagnosis is eventually made. Patients will often get really frustrated. They're given a lot of labels, but they're frustrated because they want they want to know what's going on. Why am I tired all the time? Or why is my left leg numb? And the primary care physician cannot give them a very clear reason right away. Communication is key. That primary care physician says, okay, you've done your blood profile. We're not seeing any big markers there. You're not particularly low on iron. Nowadays, they can key into vitamin D, but that's 2018 talk. That's not back a few years back. That's a new thing going on in the MS world, is the amount of vitamin D that we have. So the doctor will say, okay, I'm going to test you for Lyme's, and most MS patients are tested for Lyme because so many of the symptoms of Lyme are the same symptoms of MS. Once Lyme is eliminated, the doctor is still kind of scratching his head of what could it be next. That's usually the point now where they will do an MRI. They will do a full body MRI, not just of the brain. They will do the cervical spine, the thoracic spine, as well as the brain. Usually they can, nowadays, because of the sophistication of the MRI, and given now what the patient has told them. The patient really has to be clear about their symptoms and what they're feeling and what they're going through to get to that roadmap. The MRI usually will show if there is MS activity or not, the lesions, where they are, how many there are. And that's where the primary care physician really can get that light of, aha, I think I'm looking at multiple sclerosis. I've met many people who are on the road to looking for a diagnosis. They often will either read on the internet and will conclude, or their doctor will tell them fibromyalgia. I have learned from a nurse and a PA that it's often a catch-all diagnosis. They can't quite definitively make the MS diagnosis. A patient may not show any lesions in an MRI. The patient gets a little angry that they'll say, I know it's MS, how come you keep telling me it's fibromyalgia? That has some of the symptoms. I know the numbness or more the tingling and the fatigue can come with it. So the patient's frustrated. They're not hearing what they want to hear from the primary care physician or the neurologist, because sometimes when it's that vague, the primary care physician will send them on to a neurologist. I've heard this more than once as over my years of traveling, of fibromyalgia and not getting a definitive MS diagnosis. I don't know if that's the patient wanting a diagnosis. It's so much easier once you have a firm diagnosis. You're not in no man's land and you're not afraid of what's out there. It's almost like the boogeyman under the bed. Once you have the diagnosis, it's like, okay, I know what the enemy looks like and I know how to move forward now. So I feel badly for those who are not given a clear diagnosis or are told that it's fibromyalgia. Going on with the MS patient, the clarity will come with the MRI. They also still can do spinal tap and figure out, and in my case, it was spinal tap first and MRI second. The spinal tap, as I said, is frightening because they're often looking for obscure cancers or a tumor on the spinal cord. After that is done, then the MRI. But as I go back, the MRI is much clearer now and much more sophisticated and really can show, yes, it's MS. I have a story about a patient that I know. Never thought it was MS. He was a 17-year-old high school football player. His name was Will, and while playing in a football game, he had a head injury and received a concussion. They didn't know about a concussion protocol yet, although they were closing in on it, and he was pulled from the game, and in fact, he was told no more football for a while until this calms down. The concussion left him with vision problems. The family was frightened. The mother and father said, that's not right, and we want to see what's going on. And so they took him into his doctor. The doctor then sent him to an eye doctor, figuring that this concussion had caused something in the eyes. That's where the doctor found optic neuritis and immediately said to the family, I think your child has MS, and Will was sent to a neurologist. I have found out that very frequently, vision problems will send a patient, not knowing they have MS, to the eye doctor to seek glasses or foggy vision to figure it out, in Will's case from a football injury, and it is the ophthalmologist who sees very clearly the optic neuritis, which is an MS symptom. And so they are immediately sent to the neurologist. They then get the MRI, and they are early on diagnosed with MS, as in the case with Will. It didn't take that long for the diagnosis. It was much clearer. Other symptoms, such as spasticity, don't always start out that way. They start out more subtly, often with that numbness or tingling or what's called foot drop. whereby the patient is unable to lift the foot to step over obstacles or cracks in the sidewalk, things like that. Spasticity is clear and more often seen in secondary progressive and primary progressive. Although not always, I don't want to be that definitive. It also can be as subtle as horrible cramping in the legs or the muscles twitching in the calf. Painful, it can be dealt with baclofen, but again, it takes the patient really discussing closely with the doctor what's going on, because it can also be one of those unseen symptoms. Foot drop is obvious, clear spasticity of the arms and legs are obvious, but those twitching muscles in the eye, in the calf, are much more subtle and not always seen. It takes the patient constant due diligence of saying to the neurologist, why are the muscles in the back of my calves twitching like that? What is that? What does that mean? The spasticity can also be internal, and it can affect the bladder. So a patient might present with bladder issues, incontinence, inability to hold the bladder, or really terrible bladder or bowel movement problems. Again, it can be a muscle spasticity issue. They need to be really clear, though, speaking with that neurologist. And that's a tough one because it's embarrassing. But there are so many things out there going to the Botox, which is not easily administered, but is often used to quiet the nerves of the bladder to help with bladder spasticity. It's going to be the patient who has to push the train here. It's going to be the patient who has to say to the neurologist, my muscles are jittering all over. I can be sitting there and my arm all of a sudden flings. When they're sitting there, it's kind of like when you take your car has a funny noise, and the minute you take it to the mechanic, it doesn't make that noise. That's the same way the MS patient has to go to the neurologist. On that given day, they may not be having the spasticity, or the calf muscle may not be jumping around. They have to express very clearly to the neurologist, I am having these symptoms. What can we do about it? What is the course of action for my muscle spasticity? It's painful. The neurologist has to listen and has to trust that their patient knows what they're talking about. And also the neurologist has to know the options. One woman told me the signal from the brain that she had to go, it was too late. By the time she said, oh my gosh, I have to go to the restroom, she wet her pants. It's horribly embarrassing. How horrible for the patient. She had to tie a sweatshirt around her waist. She had to leave the program. She needs to tell the physician that. She can't just think I waited too long. She needs to tell the doctor that the minute I hit my head that I had to go to the restroom, it was too late. So that's one way to deal with the bladder problem. The spasticity, I don't suffer from it, except I do know about the leg muscles. That's why I brought that up. You can see the muscles in the back of my calves wiggling like crazy, which is spasticity. I, again, implore that the patient has to say to the doctor, how come all of a sudden I make an involuntary jerking motion? Kind of the same as the woman saying, I have to go to the restroom and it's too late by the time the thought hits their head. The patient has this involuntarily fling of the arm. Needs to tell the neurologist, why did that happen? Why does it happen when I don't even am aware of it? Can I control it? We have to give the patient the tools to ask the right questions. We have to give the physician the ability to say, okay, we need to get you to an occupational therapist. You need to start working on the mind-body connection of possibly dealing with this spasticity as exercises to help you gain some control, as well as looking at different therapy options available that are out. Prior to 1993, you were told, go home, prepare for a wheelchair. The most we can give you is Salumedrol to quiet down a flare-up. Salumedrol is a steroid. It is used to quiet a flare-up and to stop the inflammation. And if you're having an out-and-out flare-up, it will calm it down. It is not going to cure you. Neither did the disease-modifying therapies. 1993, the first came out, quickly followed by two more called the ABCs. Today, 2018, I think we now have 15 therapies. This is also extremely confusing for the patient. You're told to go and do your homework. You're told to read up on them, and you go back and talk to the doctor about which therapy option is the best. This is getting less and less, but I still hear from patients that too much of the onus is put on them to pick the therapy that they want. They don't know enough. They don't know to ask about side effects. I didn't. I thought, inject once a week, inject every day. I'm going once a week. You have to find out, what does that do? What does the long-term effects of being on the therapy? What are the reduction in relapses? Do patients, are they really armed with this kind of information? I don't think so. I don't think a patient knows to say, oh, what's the relapse rate for drug A or drug B? They won't think to even know what that means. The neurologist has to know what that is. They have to be able to say to the patient, this one presents well, this one, its profile, again, what does that mean to a patient, shows that it has very few side effects. Oh, really? What are the side effects? And then you have to balance out, okay, this one has a very great reduction of relapses, but the side effects are pretty severe. So that you're walking a fine line of a drug you're going to be on for the rest of your life, and how do you select it? Then you have to also go back to the physician and say, I'm really having side effects that are bad. I need to switch. Does the patient know they can change? They can change drugs. It's great, but they don't know that. The neurologist really has to almost be one step ahead of that patient. Every 6 months is a long time to go between neurologist visits, but that's how it works. The best thing a patient can do is write it all down, keep a running diary. You don't want to become obsessed. In the beginning of the disease, when you first start out, you're obsessed. You blame everything on MS, you think every ache and pain, you stub your toe, you think everything becomes MS. That does go away, but you do need to talk to the doctor frequently. When is it MS, when isn't it? And you still to this day don't know. You get the cold or a flu, you are sure it's MS, no, it's just a cold. That's all part of that, I call it the first year journey. But the physician has to be very sensitive to that. The physician can't just say, oh, that's part of the hysteria of finding out they have MS. Because in that information will come a lot of the course of the disease for this patient. In that information might come the spasticity, or that this patient the numbness is getting worse, or it's traveling farther up the body, or it's now in both feet. You can't just pat them on the head and send them out the door. I agree the first year is toughest because you're trying to figure it out. So that I tell the patient to keep a journal, jot down these things as you think of them, bring them to the physician. The neurologist has to be one step ahead. They have to immediately identify, wait a minute, when I first saw you, you were only having numbness in your left foot. You're now telling me that it's all the way up to the top of your rib cage. Or your right eye, you're saying, is clouding over. They need to hear all of this. MS fatigue and depression. Depression is the hardest because you are diagnosed with an illness such as MS. You're going to be depressed just by getting that label on its own. But with MS comes a high rate of depression. The neurologist needs to tap into that early. How are you feeling? What does life look like for you? What's your daily life? The neurologist should say, tell me what your day is like. Give me a Tuesday. What's Tuesday going to look like? They should be able to hear in that information if that's the patient is suffering from depression. Does it sound like a nice day? Does the patient sound down in the mouth? Why are you sad? What does that sadness last all the time? Maybe they're just sad from situational. But it's really that neurologist who needs to listen to what the day-to-day life is like for that patient. When you get up in the morning, do you have something to look forward to? Is there something that brings a smile to your face? Is there someone who brings a smile to your face? Is working in the garden making you happy? Listen to the patient. If the patient is saying, no, I'm not really interested in anything, watch out that it's not that depression and that it's MS depression. Find out if there's something that's changed in their life, if it's situational or if it's long-term. But really, neurologists, be a really, really good listener and know that patient really, really well. I do know that a lot of neurologists don't like to treat MS. And it's not so much the illness, it's that as a patient, we're high maintenance because you do have to listen to the subtleties of the illness. You do have to listen to the nuances of the changes that have taken place, the MS depression, the spasticity, bladder, all those things that, then again, there might be the patient who doesn't want to talk about them. What about those embarrassing symptoms, the sexual dysfunction, which are then going to affect a relationship or a marriage? Those are the deep-seated ones. So I implore upon these neurologists to really know the whole patient. Maybe they only should treat 10 patients with MS so that each patient is treated really individually and really in depth, and that they really would know them in the grocery store, would know that they have 2 kids, would know that their husband works for IBM, and would able to put that profile together of what that MS patient looks like from diagnosis all the way, so that the patient subtleties of the illness the doctor can pick up on, the nuances of the illness, as well as the more severe things that the patient may not want to talk about. Bring in that care partner, bring in the husband, and let them say, you know, she's just not as happy as she used to be, or we took a trip and it didn't go well. All of that's going to make us see what the patient, the whole person looks like and what's going on with their MS diagnosis.